chambers, etc. That probably, again, at some point I'm assuming you will have a practical on this. This is what I mentioned about the triangle of Einthoven. Yeah? Lead 1, 2, and 3 is meant to look at the heart on different points of view, and this is what we know as the exoaxial system, is when you put all the leads together. Lead 1 there, 1, 2, AVF, 3, AVR, and AVL, and that's why you are trying to look at the heart from different points of view, covering an axis of 6 points. Yeah? So this is, I've just explained to you electrophysiology. How does it work? We've mentioned SA node, internodal tract, AV nodes, His bundles, Purkinje. We mentioned about the synchrony of the heart. Why is this to be there? We just touched a little bit on pacemaker cells. Then we talk about an ECG. What is it? And how you record an ECG. And now we're going to move into when would you like to record an ECG, and how can you get information out of it? How do you interpret it? Okay? Again, it's very ambitious. I mean, all these aims in such a short time. But let's see what we can do. So the ECG, because it puts in paper the heart beating, the sequence of the chambers contracting and depolarizing, is the best way of diagnosing an arrhythmia. You might hear an arrhythmia when you're auscultating the patient. Yeah? It's like dun-dun, dun-dun, dun-dun. Oh, that was an arrhythmia, yeah? But you do know where the arrhythmia came from. Was that an extra beat generated in the top of the heart or at the bottom of the heart? Was that they were prematures, but these premature beats, this extra beat, were they supraventricular, generated in the top of the heart, or were there ventricular premature beats? You cannot know just by listening to the heart. You can detect them, but you do not know where they're coming from, but the ECG can tell you that. Yeah? So this is the most important reason why you will be taking an ECG, just to try to diagnose an arrhythmia that was noted on the physical exam. Yeah? The ECG will change if the heart chambers change. For example, if the heart becomes enlarged, that's going to change the waves. If you have bigger surface, if the cardiomyocytes are bigger because they are thicker, because they are longer, whatever, if they are bigger, there is more membrane to depolarize, there will be more electricity that will be moving up and down. Therefore, your ECG will change. You will have taller waves. So theoretically, you can identify changes on cardiac chamber on the ECG. Unfortunately, the ECG is not very good at it. So sometimes you have changes and you don't pick them up by your ECG. And sometimes the ECG makes you believe that you might have some enlargement of the chambers, but it's not there. So it's not very reliable. That's why I put it much smaller. Yeah? And also, because if you have, we say that the way that the cell depolarizes is by moving electrolytes up and down of the one side and another of the membrane. So you need to have enough number of electrolytes. So if you have a patient that is severely hypokalemic, that might affect how the heart can contract. Electrolyte disturbances might also affect how the ECG looks, because if you don't have enough calcium or magnesium or potassium to move up and down, you might just take longer to depolarize. So that can affect the ECG. But again, the ECG is not very good at this. So for example, a cat with kidney failure and severe hypokalemia, two cats with severe kidney failure and hypokalemia, one might have obvious changes on the ECG, another one might not, with the same level of hyperkalemia. Yeah? So it's not very reliable. It's better just to take a blood test. Yeah? So it's good to know what the ECG is good at, what the ECG is not that good at. So the best, the ECG is best at helping you when you are dealing with an arrhythmia. No, now more things. Let's see. You were told to take an ECG. You took an ECG of a patient, so you now have an ECG in front of you, and you have to kind of try to read it. So the first thing you need to know on the ECG is just get the heart rate. Just see the heart rate. The heart rate might be normal, or might be too slow, bradycardia, or might be too fast, tachycardia. Yeah? It's good to start using this terminology, this medical terminology. You will continue using it. So it's good to be able at that point probably to use two of them. Too slow, bradycardia. Too fast, tachycardia. And then you will see there will be a point in which everyone will understand tachycardia, bradycardia, etc. Yeah? For that, you need to know what is normal. So there are usually books that provide all the reference ranges, and always take things with a pinch of salt. It's not the same, a patient will not have the same heart rate if he's very relaxed, or if he's very stressed, or if he's at home, or if he's at the hospital, or the clinic, etc. So there's always some wide range of normality. Or it might be that what is normal for one dog is not normal for another one. A fit dog, a larger, might come in with a heart rate of 65 beats per minute, and it's normal for this larger, whereas a Yorkie that gets very nervous when it comes to the clinic may always come with 140 beats per minute, and that's normal for these Yorkies. Yeah? So it's good to know what's normal for each individual. And what you do is you usually calculate the heart rate on the ECG on an average. So the first thing will be calculate the heart rate. Most machines actually will tell you. The second thing is just appreciate the rhythm. And the rhythm is, maybe you want to say, is this regular or irregular? That's the question. Yeah? And how do you look at it? Well, you look at the space between the R to R interval. So you can see these are all QRSs, right? This is the P, I don't know if you can see from there, P, this is the Q, this is the R, tiny S, and a biphasic T. And then there's the next. So each of these will be a beat. Yeah, because the electricity will trigger the contraction. Yeah, and you want to know if it's regular by looking at the R to R interval. Yeah, if it's regular, the R to R interval will all the time be the same. Yeah, so you can see that in here, the R to R interval is not the same of the time. Sometimes it's longer, sometimes it's shorter. Yeah, so this will be an example of an irregular rate. Yeah, or rhythm, an irregular rhythm. Yeah, a regular rhythm, exactly the same R to R intervals. Irregular rhythm, R to R intervals are not the same. However, just to make things a bit more complicated, you might have something that is regularly irregular, or something that is irregularly irregular. Blah, 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 to say. Either follows a pattern, or is all over the place. That's what it's trying to say. What do I mean by follows a pattern? Right. In dogs, there is something that we see very commonly, and it's actually a sign of good health, which is sinus arrhythmia. Sinus arrhythmia, it means that the heart rate speeds up and then it slows down. Speeds up and then it slows down. And it does so with the breathing, and it's just something physiological. Your autonomic nervous system, sympathetic and parasympathetic, it pushes up or down depending on the pressures inside the chest. It's completely normal. Dogs, because naturally they have a high vagal tone, the parasympathetic system is in charge. The parasympathetic system, by going a little bit higher, a little bit lower, makes these changes on the heart rate. So sinus arrhythmia is actually something very good to have. And that gives an ECG with slightly different R to R intervals, but doesn't follow a pattern. Speed up, slow down. You can sometimes see that when you do a physical exam on a dog. You're auscultating and you're looking at the chest. And you can see that when the dog takes an inspiration, heart rate speeds up. And then when it's doing expiration, slows down. Yeah? So that would be another example of how you can identify that. How does it look on the ECG? Because all the waves are there, everything is fine. I have a P, QRST, P, QRST, P, QRST. So all the waves are there. So there is a depolarization of the atria, then the AV node is doing what it should do, and then there is a depolarization of the ventricles, and then there is the repolarization. So everything is like it should be, it's just not completely regular. I know it's sinus because I see a P wave, which is positive, so it looks like it should look, which means everything is started on the SA node. Yeah? It's a sinus rhythm. It's got a P, nice looking normal P, but it's sinus arrhythmia because it's irregularly irregular. And you might say, like, Yolanda, I don't see the pattern anywhere. Yes, you are right, because I gave you a very short trace. If I gave you the full trace, you will be able to see this repetition of the pattern. Yeah? So that's why sometimes you need a much longer ECG. So that will be, we said, what's the heart rate? Second, how is the heart rhythm? Regular or irregular? And if it's irregular, is it regularly irregular, like sinus arrhythmia? Or is it, no, it sounds horrendous. Or is it irregularly irregular, like chaotic, all over the place, like tum 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 tum. That's actually atrial fibrillation. I practice a lot this one. For the students, so we've done, what's the heart rate, how is the heart rhythm, and then the next thing you do is there a P for every QRS and a QRS for every P? What you're looking at the sequence of events, that everything happens at the same time. So the normal will be, as we explained, pacemaker cells on the AV node start, depolarize the atria, and then spreads to the ventricle, depolarize the ventricles. You have a P and then a QRS. But what might happen is, sometimes you might have a P that is not conducted. I'll show you some examples in a second. Okay? So you have a pacemaker cell that depolarized the atria, went to the AV node is kaput. For whatever reason, fibrosis, myocarditis, and then the AV node doesn't pass the conduction down. You will have a P, but you will not have a QRS. You will have a blocked P. Okay? And you know the problem is in the AV node. Okay? Or you might have, let's say, you might have a very unhappy cardiomyocyte, ventricular, because there is sepsis in the body. There is sepsis in the body because there is a pyelonephritis. And then you have this ventricular cardiomyocyte that is so unhappy that they want to protest. And the only way a cardiomyocyte can protest is just by contracting, depolarizing spontaneously. Yeah? So you might have a ventricular tachycardia or an accelerated ventricular rhythm, which will be slow ventricular tachycardia. And what you see in this sequence on an ECG, and I'll show you examples, is you see aberrant, wild and bizarre QRS complexes without a P. And you're like, whoa, this is not coming from the atria, it's coming from another place. Yeah? I don't see P waves. Yeah? Sometimes you might also see, for example, in a patient with, well, I'll explain that later. No, I'm going to leave it there. I'll show you, rather than explaining everything, I'll just show you examples. So we are still on the, is there a P for every QRS and a QRS for every P, or where are the P waves? You might have some P waves, like here in this example, yeah? So there is a P, QRS, T. P, ooh, P, QRS, T. P, nothing. So what you have in here is a P, atrial contracted, but the AV node did not pass it down to the ventricles. Something is wrong with the AV node that led to a block. So that is called AV block. Block at the level of the AV node. Yeah? The block at the AV node can be at three levels, 3 degrees. First degree AV block, second degree AV block, third degree AV block. That might sound very complicated, but honestly it's not. In the first degree AV block, what happens is the AV node is a bit dodgy. It takes ages to work, but eventually it does it. So what you have there is you do have a P for every QRS, but the PQ interval is prolonged. How do you know it's prolonged? Because you measure it and you compare to the reference ranges and it tells you it's prolonged. That's it. That would be the first degree AV block. Something is wrong with the AV node. It's still working, but it's a bit dodgy. Okay? Second degree AV block is like a step forward.